Yeah, thank you very much, ladies and gentlemen. This is, I'm sorry, a topic with a rather political dimension again, and there might be a long history regarding my person on surgical issues, but not on political ones. So I might also miss one or 2 points which you expected me to present here. It is the burden of surgical disease bringing us together here and seeking for solutions. It is the fact that injuries kill more than 5 people per year, that 500,000 women die from pregnancy-related complications per year, RTAs being the second leading cause of death for children aged 5 to 14, 100,000 babies born with club feet, and 40 million people to be blind or to expected to be blind in 2020 due to cataract. So what is needed? That's my task today. And I will try maybe two approaches to find an answer, but it's in trial only. The first one, I will present 4 recently published studies on the current situation. How is the shortage? The first one addressing the assessment of cesarean delivery in 26 different countries. And as you can see here, they have measured more than 500 hospitals or health facilities of different types. And as you can see in green, those are the hospitals performing cesarean sections, and red which do not. And on district level, 1/4 is not performing cesarean sections. And if you ask those hospitals, why are you referring patients to other hospitals, they were answering lack of skills, shown here in black, non-functional equipment, dark gray, and lack of supplies, light gray, and you see lack of skills is the most common cause. The second study addressing operating theater distribution worldwide, they measured 800 hospitals in 90 countries, in addition with pulse oximetry, taking pulse oximetry as a quality measure of surgical care, basically. And if you look at the percentage of operating theaters without pulse oximetry, of course, somehow, as expected, you have high percentage in Sub-Saharan Africa and Oceania, 50 to 70%. But to my surprise, you also have 30 to 50% in Eastern Europe, so not far away from Amsterdam here. Showing you the third study just recently in this year from Malawi, addressing the surgical and anesthetic capacity in all hospitals of Malawi. I would like to demonstrate the importance of the clinical officers and the anesthetic officers doing more than 90% of the work that is done. And I think task shifting means shifting the work from doctors to clinical officers, of course, is not the aim, but it is already a response to shortage. And I think that's important, and that's why we should, this is my opinion, concentrate on clinical officers, also in near future. And the last study I'm mentioning, we go back to shortage of supplies somehow, so this addresses anesthesia capacity in 22 different countries, also low and middle income countries, 600 facilities of different types as well. And you see they were measuring running water, electricity, and oxygen. Blue means all the time available, sometimes means red, and never means white, or white means never. So more than 10% of those facilities don't have any water at any time, less than 10, no electricity, and 35% no oxygen supply. So that's the current situation, basically, and it's shortage all over. But it's not only shortage of material thing, it has an impact on the health worker. If I work in such setting, then I lose my motivation, and that's a secondary effect which is very important. And even myself, I felt, being in an emotional disaster. I was part of the Malawian surgical system with all its shortage. On the other hand, I was responsible for my patients. I wasn't able to do proper surgery on him. And I was about to quit several times, but I didn't. But, closing a continent is definitely not an option. So what do we need? And what has to be done? So I asked myself, what are surgical needs? What does a surgeon need? And I crossed the low middle income countries off, and I said, are there not worldwide prerequisites to perform surgery? And this is something I would like to answer this question in 3 dimensions. Basically, the first one calling microenvironmental. Of course, you can't do proper surgery if you have unstable political situations. Maybe in Somaliland 20 years ago, maybe in Syria this week. Of course, a country needs income. You've seen a similar picture yesterday. Here you see the gross domestic product, and Africa is quite narrow. You need a society and decision-making policies not dominated by traditional beliefs, where a traditional authority decides who is going to be referred to a hospital. And it should not be dominated by religion of any kind. The last sample may be a medically indicated abortion was refused by the on-call staff of a Catholic hospital in Germany in 2013. The second level I called microenvironmental, and that's the one where surgery is supposed to be done, I think. So it needs, of course, health facilities throughout the countries. It needs the hardware, the theater sterilization unit, anesthetic machine, instruments, medication. It needs the personnel, the clinician, no matter whether surgeon or clinical officer, nurses down up to the ground worker. You see here a distribution of clinicians per 100,000 inhabitants as comparison of a few countries in Southern Africa. You need standards, supplies of systems, equipment list, quality control, and of course, you need a patient who is educated enough to reach the hospital. And the third level I would like to mention is the one focusing on the health worker. Of course, he needs surgical skills, but he also needs the attitude. And I've just taken this photo 3 weeks ago in a hospital in Malawi. So this means reduction of surgery by 20%. Someone working in surgery should have perspectives to remain motivated. He should be able to do his work independent from political background and financial constraints. And you need a team, and to me very important, you should have a mentor as well. So this was the third dimension of surgical needs, I think. And now we have to go one step forward. How can we improve? And I want to add 2 questions. The first one, what to do? And also to answer this question on this micro-environmental political level, I think I shouldn't do it, and it will be done by Mina Cherian maybe during her keynote lecture later on. But I think I should emphasize the effort the WHO has done already in collaboration with other organizations, societies, and ministries of health. On micro-environmental level, and this is where most of us work, I would like just to give an example from Malawi. It's about trauma care. Malawi, the health sector of Malawi is divided into 4 health regions with 28 districts. And the distribution of orthopedic surgeons 10 years ago, there were just 3 at the hospital attached to, or in collaboration with a private hospital, one in the capital and one in Zomba. And 10 years later, the number of orthopedic surgeons has doubled, but the distribution hasn't. It hasn't changed. A complete different picture appears if you look at the orthopedic clinical officers. A clinical officer training program has been started in the 90s, aiming to distribute all of them throughout the country, and it has become a story of success, which is still going on, so there's nationwide availability. So having those clinical officers, we were also aiming to improve the quantity and the quality of trauma care, which is important. So we tried to introduce an external fixator in the 90s, but then only a few years later we found that external fixation for open fracture was only done on central hospital level and not in the districts anymore. So as a response, we tried to re-establish the program, at least in the south. So we did a trauma week. We invited all clinical officers. We still found the fixators in the warehouses of the district hospital theaters. But then it was the Germans who drew out the country. We had to go home. There's no follow-up. There's no quality control. So this sample is full of surgical needs, and it is full of solutions, but yet we are still failing. The second question I would like to ask was how to improve surgical care. And here I would like to cite a very important paper composed by the Bellagio Essential Surgery Group in order to reduce those DALYs, the disability adjusted life years, meaning the years lost due to disability, ill health, or early death in regard to surgical conditions. In order to reduce those DALYs, they recommended to concentrate on district hospitals, to concentrate on trauma care, to expand surgical skills, and to improve access to surgery. Those were the same points, and furthermore, they advised any stakeholder to check his projects to remain sustainable, low cost, eminently applicable, integrated into the national health systems, and locally based or patient related. Also surgical needs. So when preparing for the presentation, I spent nights in Google and Yahoo searching for medical projects within Malawi in collaboration with international organizations, and I stopped at about 200, of which quite a lot of them were surgery related, in fact. So with those arrows, I want to show you almost all hospitals have international partners. But I, after having been in Malawi for 3 years, I hardly knew 5 of them. So there is urgent need to come together and to coordinate our projects. To conclude, I would like to change the site and to talk to you maybe as a patient. I want to be treated by a clinician who is focusing on me, skilled, motivated, well-equipped, and part of a team. And, you know, with all this shortage, if we concentrate on this, we don't have to spend $1 more, and which is also important, we can reach or improve within a short period of time. So I think that's also a surgical need. To conclude on this political level, I don't want to risk basically. It remains challenging. I'm not very optimistic because I think improving surgical care needs a functioning infrastructure of a country, and we rarely find this. But as a surgical team, as we are sitting here, I think we should take the responsibility to convince the governments to consider surgical conditions a major health problem and to push them into action. On the microenvironmental level, I think projects should be locally based all the time, focusing on the patient. Sustainable, integrated into the national health systems. If we combine projects, we might get more efficacy because we can't, with our small projects, we can't meet all demands we have to meet to get a good project running. My personal opinion is more patients die due to the lack of communication, information, and reliability than they die of bad surgical skills, but we can discuss. And maybe the last sentence, one-to-one, very personal partnerships, projects, and mentorship remain the key factors to improve surgical care. The patients will look at us in future as well. Thank you very much.
Thank you very much for this beautiful overview and presentation. And it shows really how an individual surgeon looks beyond the walls of the theater and gives a systematic way in seeing how these things work. I think it's a very nice example how to do this. And Anna yesterday said that the Dutch were very systematic and she liked our country, but if you see this German contribution, you see that really if you have strong structure, then maybe you need also to go to Germany. You have strong cars and have strong contributions, so thank you. Yeah, we will do. We will try. We have a short time for discussion, some 5 minutes, and then we have coffee. Who can I give the word? Yeah.
Thank you very much once again. I'm astonished at what I'm hearing from the surgeons. I think they've become politicians and other things. Dr. Mothes, talking about the microenvironment, you talked about the World Health Organization and other societies, Red Cross, etc., etc. I wanted to urge the doctors from the, what I would call developed countries, to help influence the UN, bodies like World Bank in changing the macro environment. For example, I'll show you a few things. United Nations has something to do with peacekeeping. World Bank has something to do with the pressure on leaders in shifting of resources. I just wanted to show you that in East Africa, in Somalia, we have some East African countries which are involved in trying to bring peace. Now, some of our soldier health workers, they are doing something. Army doctors are now involved in public health. They are involved in fistula care for women. They are involved in managing the wounds, not only of their soldiers, but also of the opponents and also the civilians. And I think that is an important contribution. So if the United Nations, for example, goes into peacekeeping somewhere else, they can also contribute other things that is essentially stopping the fights. Thank you.
Any comment on that? Is there any military surgeon here who goes in these missions? He may maybe comment on this. But I know some Dutch surgeons who work for the military and they go there and they only are to treat, I think, in 90% their own soldiers. But this is a clear question. If you go there, why not help the whole population? Is there any military surgeon here? No. You want to comment?
I'm not a military surgeon. I'm not a surgeon at all. But must there be conflict for the UN to intervene? I'm asking that question. If the UN is sincere about making a difference and finding solutions for the problems of developing countries in Africa, we welcome the UN to come and do something about surgical care in peaceful countries as well. Thank you.
It might even bring peace, not? Now I have many. Okay.
Thank you very much. Thank you for the fantastic talk. I really appreciated your insight into Malawi and all that. The two factors that you mentioned, macroenvironment, the political will health in Africa is not a priority of the governments. Would you agree with that? And then the economic situation is not rife to support health. What would you say about that?
Yeah, I fear to become negative again and to say, yes, you are right. I think, you know, if you ask the presidents of those countries whether health is, whether they take health as a major thing, they will answer yes. But then if it comes to their daily work, they just shift the money from the malaria drugs to the tanks. Although the percentage of health expenditures in Malawi are, for example, higher than for Germany. But it's not enough, definitely they do. So, you know, I'm a surgeon only, I'm sorry. And I also fear, and this is also the answer to the first contribution, I think we as surgeons, of course, we always concentrated on surgery, and I still feel we should continue. But on the other hand, we didn't have enough power within the UN, Gremia, and WHO. So there was no one supporting us. And what we face now is the result of this. Yeah. So we also have to think about it, and we should really have supporters. And if no one is supporting us outside from the surgical community, then we have to take over.
Yeah. We'll discuss this further on the day. Dr. Mengistu?
Thank you so much. I really appreciate this wonderful presentation. I just would like to contribute a bit. I'm not very optimistic as you are, because not all is lost. Africa has a lot of potential. And I also believe that our leaders are more concerned for the people than we surgeons. So on this regard, the potential in Africa, for example, is very huge. But unfortunately, the surgical care is not to the level of our desire. Even for the last 1 month, one of our presidents has died in exile, and one other president had his prostate surgery somewhere in Europe or America. You see, this is the scenario where we are in. And to reverse this, and again also, we need to support our leaders by feeding them with evidence. Research is very important. Now, one thing of concern in Africa is the number of people going abroad for treatment to Asia and Europe is tremendous. We don't know how much money, billions of dollars, the country is losing because of this. But during our discussions, this is my contribution, we have not addressed the role of the private sectors on this. There is a major market. As any other business, anybody coming to invest in health, I think is profit-making. So by doing this also, we are challenging the health system so that, you know, the sense of competition is created, and the government institutions also will wake up one day. So I think always we need to consider to include the private sector in health delivery service. Thank you.
Very interesting contribution. Private investment in medical care in Africa might be a subject. One last question, that side.
Hi, thank you for the talk. I'm Shelby. I'm a surgical resident from the States. Don't hold it against me, please. When talking about surgical need, I think there's two ways to look at it. That you highlighted a great point of view from the hospital-based level, that places don't have pulse oximetry, they don't have surgeons, they don't have this. When talking about surgical need, there is a whole broad spectrum of data that has been started from the population-based level for people who are unable to access such care. For example, Surgeons Overseas, the organization organization, they created a survey actually by a Dutch doctor, Dr. Rino Groen, that showed that in Sierra Leone, 25% of people had an unmet surgical need that were unable to access hospital-level care. Same study was done in Rwanda, 7%. We just did it in Nepal, 10%, with barriers being fear, mistrust in the system, unable to access care due to money, and things like that. So I think when we talk about surgical need, that also needs to be highlighted from a population level. Why aren't people getting care? And we saw this in the film last night, The Right to Heal. You know, you have people with large masses that don't know that they need care, or if they do know, they don't come until they have stage 4 breast cancer or stuff like that, that we need to highlight at the population level why people aren't going to get surgical care.
Yeah, you're definitely right, and I just wrote it down as it needs a patient who is educated enough to come, but of course it should be possible to come. But I would like to answer, I support your private, I call it business idea very much. And I think we can't expect, you know, I also prepared, you know, 25 years after the wall came down, and I'm from East Germany, and expected to go to Amsterdam in 2024 for the first time of my life. So since the wall came up in '63 up to '89, there were 3,400 doctors leaving East Germany. So early on we said, is it all for money, or because we didn't have you know, enough education at home and not good circumstances? Of course, that's very important, but to improve those circumstances, we should include the private, let's say, money making as we have in UK. Yeah, I strongly think this is an important factor.